So good afternoon everyone, I'm Dr. Darshana. I'm a pathologist with Datar Genetics, and I'm glad to present our data on lung cancer today. But before I actually run through all the figures of our experience, I'll just try to briefly introduce about our company. So Datar Genetics journey has started in 2013. We are a molecular diagnostic testing service provider focusing only on oncology. While providing the routine diagnostic sequencing solutions on tissue and liquid, we also have some unique solutions where there is, which are innovative. And I'm proud to say that our journey though started in India. Now we have labs in UK and USA, and we currently service over 40 countries. And this has been, I think, achievable because our sole focus since we began our journey has been on quality, and that can be seen with the accreditations that I can show here, which is NABL, CAP, as well as CLIA accreditation that our India facility as well as UK facility boast. Of course, NABL is only for India. So now going to the experience. So first, when I started data mining for this presentation today, first thought that as a pathologist obviously came what has been the histopathological subtypes that I observe in my data. And as you can see here, adenocarcinoma stood out the most common histopathological subtype at 86%. Now, when I looked up the literature for the incidence rate from India, of course, adenocarcinoma varied from, about 1/3 to close to 50% of incidence. But for obvious reason, even though the guidelines like NCCN, for example, do recommend broad molecular profiling even in squamous cell carcinoma, but the clinical outcome has not been great in squamous subtype. And that's why maybe clinicians do prefer sending only adenocarcinomas, or more commonly the adenocarcinomas are tested, and that might have been the reason that we see that subtype as the most common one. The median and mean age between male and female, they had some difference, though not statistically significant. The presentation or the testing happened in women at slightly earlier age, but of course not statistically significant at all. When it came to age distribution of these histopathological subtypes, in this third decade, we had very few cases, absolutely few cases. Adenocarcinoma was most commonly seen in the 7th decade, and squamous cell carcinoma, of course, was again common in that decade only. However, adenocarcinoma percentage in the 3rd and 4th decade was not so uncommon. The early stage presentation is significant in our population. Now, when looking at the gender-wise comparison of incidence versus the molecular testing, we know the female incidence in female statistically for lung cancer is less. They comprise only about 1/4 of the cases. But if we see the comparative prescriptions for molecular testing, female had were more commonly tested for molecular testing. Again, for maybe obvious reason that non-smokers people are known to have higher incidence of driver alterations, and most of our Indian women being non-smokers, again clinicians tend to do molecular testing more diligently in women maybe, and also maybe whether female present at advanced stage. But my data set, I did not have much information on staging for majority of the cases, hence I'm not presenting on the staging difference between the genders. So what are the panels that we provide? It is a kind of disclaimer also that whatever data I am presenting is not uniform. I have some small panel testing data which is focusing only on the 12-gene panel, whereas some data is from comprehensive genomic profiling. So most common driver alteration, of course the denominator is uniform, but when I go to certain unique or uncommon biomarkers like microsatellite instability, the denominator is much less. So when coming to the actionable drivers, of course the EGFR stood out, and I tried to compare it with the TCGA incidence, as I think it is a well-proven fact now. Our Indian, especially and also the Southeast Asian, we see much higher percentage of EGFR, and that also was seen in our data set. We had close to 39% incidence of EGFR alterations. The KRAS or ALK was more or less similar. One important point here that I felt was quite clinically relevant would be the incidence of HER2 amplification and ALK fusion in neuroendocrine. We do know that neuroendocrine morphology also has EGFR quite significantly. Even though the outcomes are not great, we see EGFR. But in our data set, I saw that HER2 amplification and the ALK fusions were also quite significantly present in the neuroendocrine subtype. In the neuroendocrine, I have data of small cell as well as the large cell neuroendocrine and other low-grade neuroendocrine tumors, although of course their percentage is less. So, so this is what I was referring to, and the squamous morphology, the MET amplifications were quite common, and significantly, if we compare the percentage, were more common compared to adenocarcinoma. I think this is a unique finding. I haven't been really, maybe I missed, I don't know, I didn't see any literature citing that squamous morphology had more common MET amplification or MET exon skipping alteration, but our data set clearly showed higher incidence of these MET alteration in squamous as compared to adeno. And again, comparing these driver alteration gender-wise. So EGFR, of course, was significantly more common in women, so was the ALK alteration. Men, of course, because of maybe the smoking, had the KRAS alteration more common compared to women. And also the HER2 mutations, because now there is significant options for even HER2 mutations in lung cancer, the HER2 mutations were also more commonly seen in men. And I think that is relevant. And they also had higher incidence of RET fusion. EGFR, ALK, ROS1 were of course more common in the women. So was the BRAF. Now comparing the incidence of EGFR variants or the subtypes in tissue versus liquid, of course the exon 19 was the most common, whether it was tissue or liquid, and next was exon 21. And as maybe the earlier talk of liquid biopsy did refer to, that liquid biopsies are far more sensitive for acquired resistance mutations. Aligning with that, I had T790M more common in liquid versus tissue, because of course it's a resistance mechanism, and so was the, okay. And now coming to the coexisting alterations in EGFR positive cohort. So here the denominator is only those patients who had one sensitizing EGFR mutation, and I tried to look at what were the other alterations that I could see. Concurrent EGFR alteration, the resistance alteration like T790M or C797S, of course, were more commonly seen when it was a liquid sample that I was using. So was the KRAS and BRAF alteration. So these mutations which are known driver for resistance, acquired resistance to EGFR tyrosine kinase therapies, were more commonly seen on the liquid data. Coming to distribution of KRAS variant, because now we have option for KRAS G12C, I thought that I should really look into its incidence. In our data also, KRAS G12C was the most common alteration, and which is targetable now. And the next common were, I think this is a pretty known fact, but the data did concord with whatever information is out there already. For the immune checkpoint inhibitor biomarkers, I think I already discussed microsatellite instability high status is not very common in lung, and that same was the finding in our data. We had only 0.5% of the patients of lung cancer who had microsatellite instability high status. The TMB high was, when I say TMB high, I am referring to 10 mutes per MB. The TMB high was seen in close to 33%. Now TMB high and the PDL1 positive status was relatively less common to the prior, less common compared to the literature evidence that I saw. So our data sets, the Indian patients, I did not find equivalent TMB high status as well as PDL1 positivity. So now this was about the data. I also wanted to take this opportunity to enlist some challenges which we face as a lab. So when I was doing this data analysis, so much demographic information was missing, because whenever we get a sample, patients or clinicians are not really focusing, because it's a private laboratory testing. We do not have access to the hospital records and patient records. But when we are publishing data regularly, it would be be more meaningful if we have insights to that the data being shared. Of course, not details, but the prior smoking history. Many a times, and I think clinicians here can play a role. Patients are more proactive to share that data if clinicians sound them once. Otherwise, they feel कि इतना क्यों पूछ रहे हो, मुझे पूछ के ही report बनाओगे. So it becomes very difficult to have that data. Another aspect that is very critical is the tissue quality that we receive. Majority of the times, by the time we receive the tumor blocks, the tumor is used up in immunohistochemistry analysis. It's a point of debate whether now adeno versus squamous really matters or not. Of course, it still matters. But I think that the tissue utilization has to be done judiciously even in pathology laboratories. And so it's a fixation. So many patients who can really benefit from these targeted therapies do not achieve that because the nucleic acid quality is so degraded by the time the block is made. And there are certain various challenges. I'll just take 30 seconds when it comes to the data that is churned out in the report. There are so many variants which may have conflicting interpretation across databases. They may have conflicting interpretation for somatic versus germline. And when the report is floating around, there might be, you might refer to one database and feel, okay, this report may be wrong. It may not be so because there is a lot of effort and experience of 13 years going into there. Or for any laboratory, it is better. I would request to really discuss what is the evidence that led a particular lab to classify and give a particular interpretation for a variant, because that is something may impact the patient management as well. Yeah, sorry. So that's all. Thank you so much for your time.